All right, let's dive straight in. We're going to break down the clinical management of benign prostatic hyperplasia, or BPH. If you're working in primary care or really any field of medicine, and especially if you're prepping for exams like the MRCGP, this is core knowledge you use every day. So let's get right to it.
So just how common is this? Well, this number really puts it into perspective. 50% of men over the age of 50 will have some evidence of BPH, and that number jumps to a staggering 80% by the time they're 80. The bottom line? You are going to see this, and you're going to manage it, a lot. So having a solid grip on it is absolutely non-negotiable.
Okay, so what is BPH fundamentally? It's a non-cancerous growth of the prostate gland. But the really key thing to understand is the direct link between that growth and the symptoms. As the prostate enlarges, it physically squeezes the urethra, kind of like stepping on a garden hose. This blockage then forces the bladder to work overtime, and that combination is what causes the whole cluster of symptoms we call LUTS, or lower urinary tract symptoms.
Right, so how does a patient with BPH actually present to you in the clinic? Let's break down the key symptoms you need to be listening for, and, just as importantly, the potential complications that can happen if BPH is left untreated.
Now, this is a crucial distinction to make. We split the symptoms, or LUTs, into two buckets. On the left, you have the voiding or obstructive symptoms. These are the direct result of that hose being stepped on. Things like a weak stream, trouble getting started, and feeling like you haven't emptied properly. Then on the right, you have the storage or irritive symptoms. This is the bladder's reaction. It's getting irritable from having to push against that blockage, leading to urgency, frequency, and getting up all night. Nailing down which category is bothering the patient most really helps guide your treatment.
And this slide right here is exactly why we take BPH so seriously. It's not just about annoying symptoms. If you don't manage it, that incomplete bladder emptying creates a pool of stagnant urine, which is just asking for recurrent UTIs. If the blockage gets really bad, it can lead to acute urinary retention, a true urological emergency. And over time, that back pressure can travel all the way up to the kidneys, causing damage, what we call obstructive uropathy, and even renal failure.
Okay, so a patient comes to you with those symptoms we just talked about. What's the plan? Let's walk through the systematic approach to work them up, confirm it's BPH, and just as importantly, rule out anything more sinister.
These are your 4 cornerstones for the initial workup. First, a urine dipstick is an absolute must to check for infection or blood. Next, you'll want to check their kidney function with urea and electrolytes, especially if you're worried about that back pressure we mentioned. Then there's the PSA test. This requires a proper discussion with the patient about the pros and cons, but it's important. And finally, the IPSS score, which is a fantastic tool for getting objective data on how bad the patient's symptoms really are.
And speaking of the IPSS, here's how it works. It's basically a simple questionnaire that turns a patient's subjective complaints into a hard number. A score from 0 to 7 is considered mild, 8 to 19 is moderate, and anything 20 or above is severe. This score is so useful because it's not just for diagnosis, it's what we use to decide when to start treatment and to track whether or not that treatment is actually working.
So we've confirmed the diagnosis, we've scored the symptoms, now it's time to actually do something about it. Let's get into the first-line drug treatments, based on major clinical guidelines like those from NICE.
And here it is. This is the single biggest take-home point for management and a classic exam question. If your patient has an IPSS score of 8 or higher, so their symptoms are in that moderate to severe range, the first-line go-to therapy is an alpha-1 antagonist.
This table is your cheat sheet for the 2 main drug classes, and understanding the differences is absolutely vital. On one hand, you have the alpha-1 antagonist, like tamsulosin. They work fast by relaxing the muscle around the prostate and bladder neck. They open the pipes, but they don't actually shrink the prostate itself. On the other hand, you have 5-alpha reductase inhibitors, or 5-ARIs, like finasteride. These work by blocking the hormone that makes the prostate grow, so they actually shrink the prostate. But, and this is key, it can take up to 6 months for them to work. Also, remember this clinical pearl. Finasteride can cut the PSA level in half, so you have to double the lab result to get an accurate reading. Notice the different side effects too. This is all crucial for choosing the right drug for the right patient.
But, of course, it's not always that straightforward. What do you do when one drug just isn't cutting it? Let's look at the next steps in the treatment plan, including combination therapy and other add-on options for those persistent symptoms. So when do we use both types of drugs together? Well, the evidence for this is really solid, thanks to landmark studies like the mTOPS trial. What it showed, basically, is that for men who have both really bothersome symptoms and a significantly large prostate, hitting the problem from both angles with an alpha blocker and a 5-ARI is better at preventing the condition from getting worse. It lowers their risk of things like acute retention or needing surgery down the line.
Now here's a very common clinical scenario. Let's say you've put a patient on an alpha blocker. Their flow is improved, but they're still running to the bathroom constantly with that urgency and frequency. This tells you there's probably an overactive bladder component going on. In this case, the next step is to add an anti-muscarinic drug. This medication specifically targets that bladder irritability, calming it down to relieve those persistent storage symptoms.
So, we've tried medication, maybe even combination therapy, but it's still not working. Or the patient is developing complications. This is when the conversation has to shift towards surgery. This is the definitive way to treat BPH.
And when you're thinking about surgery, there's one procedure that has stood the test of time. Despite all the new techniques out there, the transurethral resection of the prostate, or TURP, is still considered the gold standard. For most patients who need surgery, it provides the biggest and most lasting improvement in their symptoms.
And that brings our high-yield review to a close. We've walked the entire clinical path, from understanding just how common BPH is, to assessing it with tools like the IPSS, and then moving through a step-by-step management plan from first-line drugs to surgery. And that leaves us with this final thought. With TURP having been the benchmark for so long, what's next? What will be the next big innovation in surgical treatment that's maybe less invasive but just as effective? That's definitely the space to watch in urology.